Yeah. Good afternoon, teachers. Good afternoon, respected teachers. Myself, Dr. Rohit Kumar, Dr. Sudhir, and Dr. Bimal Kahar. We are representing IPGMER and SSKM Hospital, Kolkata. And we are going to present a case of a 59-year-old male patient, carpenter by occupation, a non-diabetic, non-hypertensive, non-smoker, and non-alcoholic, admitted with the chief complaint of dyspnea on exertion and rest for last 3 months, as well as leg and facial swelling for the past 1 month. The patient was apparently all right 3 months back when he developed dyspnea on exertion, which gradually progressed to dyspnea at rest as well. Patient also had a history of chest discomfort on exertion, which was retrosternal in location and was radiating to both arms and was relieved on rest. There was at the same time a history of orthopnea was also present. Also, history of palpitation on exertion as well as fatigability was there. There was no history of syncope or pre-syncope, as well as there was no history of similar illness in the family members, and no history of any cardiac illness or sudden cardiac death in the family members. Now, coming to examination, there was no pallor, no icterus, no cyanosis, no clubbing.
Please wait. This is all the history that you want to say, because we should just pause after the history.
Yeah. Sir.
Is there anything else you want to say? Because you've not talked of, let us say, past history, any treatment history in the last 3 months. Go back to the page 1 of your slide.
Sir, there is no previous history, no significant past history is there. And for the last 3 months, he was taking some treatment at some local doctor. There were no documents with the patient. When the dyspnea progressed, the patient presented to us.
What do you think is the cause of chest discomfort for last 3 months? Hello?
You will have to give the provisional diagnosis from the history.
Now, what was the reason for what was the nature of the chest pain? Is it angina or some other sort of chest pain?
So it seems to be anginal chest pain which is retrosternal and radiating to both arms and getting relieved on rest. So on this history, just by this history, we were suspecting, and given the age of 59-year-old male patient, although there were no risk factors present, but with this history, we were suspecting maybe this is an anginal chest pain, and due to that, the other symptoms are consequence of this anginal chest pain pointing towards maybe CAD.
You said that you think that it is a myocardial infarction and going into heart failure.
Sir, that is what we want to say, sir.
Is there any history as to MI? Because what you have told us is only chest discomfort on exertion.
No, sir. There is no history suggestive of MI.
So how can a patient of angina will go into failure?
Yeah.
Can you summarize the history for everybody's benefit? Because I think it's a little scattered. Just summarize the history. We want to know which symptom started first. Was it angina or dyspnea? Which one started first? That also we don't know. Please summarize the history.
So the dyspnea started first.
You summarize the history.
Sir, summarizing my history, the patient, a 59-year-old patient, presented with dyspnea on exertion for the past 3 months, which has gradually progressed to dyspnea at rest in this 3 months duration, and as well as there is signs of facial as well as pedal edema is there for the last 1 month. This is the chief complaint, sir.
No, but I think if you are giving history of chest discomfort, which is angina, it's a very, very important history. It has to come in the chief complaints. We don't know what is the duration of that particular symptom that you're talking about. Especially if you're thinking of coronary artery disease, then you have to elaborate more on the chest discomfort part of the history.
Sir.
Did the chest pain disappear after the onset of dyspnea, or was it present throughout the 3 months?
No, sir.
You're not audible.
Is it?
We can hear you.
Can you come close to the mic, please?
The history of... Ma'am, are you audible?
Yeah.
Yeah,
You
yeah.
can.
Very faint, please.
The patient has dyspnea, ma'am, for last 3 months, along with chest discomfort, and which persists for last 3 months till the admission.
Was it a nocturnal or
No diurnal variation.
is there any history of orthopnea and PMD?
Yes, sir.
Yes, there is orthopnea.
There is orthopnea, sir.
How long is he orthopnic? For how long?
For last 3 months.
So you are saying that he is dyspnea on exertion, which has now gone on to rest, but he had orthopnea 3 months ago also. It started off with orthopnea and also chest discomfort. Everything started together. Is that right?
Yes, sir.
Now comment now, because you have mentioned dyspnea and exertion. At that time, orthopnea is not there.
3 months.
3 months. Initially, sir,
I think it is very, very important that you tell us the temporal progression and temporal onset of symptom. That is very, very important. Otherwise, how would we ever make a diagnosis if we don't know that? So you need, see, there are 3 symptoms we're talking about, or rather 4. One is dyspnea, orthopnea, swelling, and some symptoms suggestive of angina, not MI. You need to tell us which one started when. We only know about dyspnea and leg swelling. We don't know about orthopnea. We don't know about chest discomfort. And also tell us how bad is this chest discomfort, how many episodes is he getting every day, or is it an occasional finding? So all those things need to come in your history before you think about making a possible diagnosis based on history.
ma'am, actually, the dyspnea
Please come close to the mic.
Please come close to the mic or
and chest discomfort develop simultaneously. As I leg swelling and facial swelling, the puffing develop 1 month after, 2 months after
Sorry, I can't hear you. I don't know about others, but I can't.
I also cannot hear.
Increase the volume of your computer. Please increase the volume of your computer.
Now, okay, ma'am.
Yes.
Yes, now it's okay.
Ma'am, dyspnea and chest discomfort started simultaneously at 3 months back, and followed by after 2 months, patient developed leg and facial swelling. This is the main complaint.
Very good. I also want to know the chest discomfort. How often does it come? Is it always related to exertion? Is there any history suggestive of acute coronary event?
There is no acute coronary event.
Come close.
Come close to the mic.
There is no acute event is there, but the patient during doing any household work, patient develop the angina and also the dyspnea.
Can you please give us the class of this angina?
CCS class 3, ma'am.
Class 3?
2, 3, ma'am. 2 and 3 or 3.
Okay.
I want to just elaborate on what ma'am was asking right now. Out of all the cardinal symptoms in cardiology, which are present in this patient, except syncope, everything is present: palpitation, fatigue, chest pain, dyspnea. Why did you choose only dyspnea to be the chief complaint and not the others?
That is what the patient said. The patient, his main complaint was, since he is a carpenter by occupation and he is a daily wage earner sort of a person. So his chief complaint was, whenever I go to work, I feel very dyspneic. I feel a lot of shortness of breath.
This history of chest discomfort that you're telling us later, see, the patient will tell you 100 things. That doesn't mean you present it like that.
Correct.
You are the person who has to filter what is important, what is not, because the onus was on you to make a diagnosis, not on the patient. Okay, so don't say that patient said that. I want to know whether this history of chest discomfort was on your questioning him or it was offered by him.
On our questioning.
So it's possible that his history of angina is something, or it's not so reliable, because when patient is not so much bothered about this angina, it is possible that that's not his primary symptom. Maybe you asked him about chest pain specifically, and then you sort of got into this conversation, and that is the reason why you seem to have written it almost insignificantly in your history. It's not even in chief complaints. It's just a passing remark. So as a physician who's asking the history, I think you need to decide whether how much importance you want to give this or not, because this totally takes your diagnosis to a different level. If you say there is chest discomfort, there is no question that we have to think about coronary artery disease. But if it is not there and dyspnea is the dominant symptom, then you go away from that particular diagnosis. So I think the onus is on you to tell us whether there is angina or not.
I think they have clarified that this is an angina of short duration of 3 months. So the total history of illness is only for 3 months. That's right?
Pardon?
The total duration of illness is only for 3 months. There is a short, it's a short history. So before that, the patient was all right.
Yes, sir.
Agree? Okay.
Yes, sir.
Okay.
Usually, students, please come near the mic while speaking. You are not well audible. And we have exhausted nearly 15 minutes on the history.
Yes.
So, can you summarize from the history?
Summarize the history and tell us what is your possibility based on the history. Then we'll quickly go to the exam.
Yeah.
Sir, on summarization, there is history of dyspnea on exertion, as well as there is a history of chest discomfort, which on the basis of history and the radiation seems to be an anginal pain. So on summary, it's as well as leg and facial. So it seems the patient is in failure due to maybe coronary artery disease. But at the same time, there is no history of ACS. There is no history of acute coronary syndrome.
So your first diagnosis is coronary artery disease leading on to ventricular dysfunction and heart failure, I suppose.
Yes, ma'am.
Do you have any other differential, another diagnosis besides this?
Any?
Possibility, please.
Any congenital heart disease?
We can't hear you.
At 59.
We can't hear you. I think you'll have to come to the mic.
You have to use a mic or something.
At 59 years of age and with no previous history, any significant past history, we won't keep congenital heart disease that high up in our differential diagnosis.
That's okay. But do you have,
okay.
Do you have any other diagnosis or no? That is the question. Okay. See,
we were thinking cardiomyopathy. Any cardiomyopathy?
Yes, you should think about that because the history of dyspnea and all that is there. There is no history of acute event before that. So I think you have to think of cardiomyopathy, and it is possible that with that cardiomyopathy, he is getting some kind of an angina. So
yes, what is that possibility of cardiomyopathy and angina? How do you explain that?
The increased thickness.
Go near the mic.
I think either one of you speak or you have to go to the mic, whosoever is speaking, because we can only hear the person in the middle.
So basically cardiomyopathy, if there is thickening of the myocardial involvement, that can lead to
demand-supply mismatch.
Demand-supply mismatch.
Any other
possibility?
There can be, although there is no previous history, the patient does not give history of syncope, but demand-supply mismatch can there be in aortic stenosis as well.
Yeah, in valvular heart disease, you should have thought of.
Sir.
Which valvular heart disease? Which valvular?
Sir, in this case, we were thinking of aortic stenosis might be one of the possibilities.
Aortic stenosis.
I think it should go for examination.
Yes, please.
Yes.
Can it be L-kappa also?
Sir?
L-kappa.
L-kappa.
Yes, sir. L-kappa usually is a patient in earlier age. This is a 59 years. It is a very rare.
It is no L-kappa can present in 2 ways. You know, very rarely it can present at 59.
Actually, sir, rarely diagnosis in the rare
L-kappa.
Okay.
L-kappa, but shall we move on to examination?
Yes.
On examination, moving on to examination, sir, there was no pallor, icterus, cyanosis or clubbing. There was bilateral pitting pedal edema in bilateral lower limbs extending up to the knee joint. Pulse rate was 62 per minute, low volume, regular. All pulses were well felt, were palpable, and there was no radial or radiofemoral delay. The respiratory rate was 16 per minute at chest, abdominothoracic. JVP. Now coming on to the JVP was engorged on sitting position itself. We were able to visualize the JVP column on sitting position, upright sitting position itself. It was 12 mm of Hg. The JVP calculated was 12 mm of Hg. There were 2 positive and 1 negative waves which were prominent, which we might show you in the video as well. And the Kussmaul sign was negative. At this point, we asked the patient to take a deep inspiration when the JVP column fell down. So Kussmaul sign is negative.
Can you tell us JVP in centimeters of water?
Besides 16 mm of water, H2O.
Okay.
So now coming on to cardiovascular examination. Starting off with inspection, the pulsation was visualized at the 5th intercostal space. On palpation, the apex was felt at 5th intercostal space in mid-clavicular line. There was no thrill or palpable heart sound, as well as there was no parasternal heaving. On auscultation, the first and the second heart sound were normal. The S3, we could hear a third heart sound, S3, in the left parasternal area on 4th intercostal space. There was no 4th heart sound. There were no murmurs.
Can you tell us the movement or the loudness of S3 with inspiration and expiration?
On SC with inspiration, it was increasing.
And when you say second heart sound was normal, you need to tell us about the split also.
So there was the splitting of the second heart sound was normal. There was normal splitting of the second heart sound.
Both components, loud intensity was okay, normal.
Yes, sir. Yes, sir. It was normal, sir.
Because in diagnosis there are 2 procs. One is JVP, one is second heart sound. That we have to clearly mention.
Sir.
The S3 was from the right side or the left side, RV or LV?
Left means left parasternal area में right sided SC.
Okay.
Proceeding further, respiratory system examination, sir. There were bilateral basal fine crepitations were heard. Otherwise, respiratory system examination was unremarkable. On GI system, the abdomen was distended, which was dull on percussion, and the liver was palpable 3 cm below the costal margin.
Was there any free fluid?
Yes, sir. Yes, sir. There was shifting dullness.
Yeah, you have to say that, no? Just dull on percussion is not enough.
Sorry, ma'am.
Okay.
So, on the basis of this much of history and this much of examination, we reached a provisional diagnosis of congestive cardiac failure with the etiology which we previously discussed.
I think this is not a diagnosis. I'm sorry. Yeah, that's a physical finding. That's not a diagnosis. No, you have to give us 1, 2, 3, 4 differential diagnosis of the patient, of the condition. CHF or CCF is not a diagnosis.
So basically, first is which, as we have discussed, ischemic origin, coronary artery disease. The other.
Coronary artery disease and leading on to what? You tell the diagnosis means it has to be full, no? Coronary artery disease, LV dysfunction, pulmonary hypertension, right heart failure. Go like that and tell us.
Sir, sorry, sir. So, our first differential diagnosis will be coronary artery disease with left ventricular systolic dysfunction, which leading to.
But you got right-sided S3.
Right-sided S3.
Now you are saying LV dysfunction. There are no features to say LV dysfunction.
No features.
Is there pH? You said no pH.
No parasternal heaving. P2 is normal.
Then what is the reason for the RVS3?
So that is where we feel that a much more possible cause might be restrictive cardiomyopathy. There must be restrictive cardiomyopathy. That might be a cause.
Hey, the onus is again on you to give us a diagnosis. We should not be questioning you like this. Tell us what is your number 1 diagnosis, what is number 2 diagnosis, what is number 3 diagnosis. You have to go like that. We are not the ones who will ask you. Now you are trying to put
first diagnosis
above CAD. When we asked you the diagnosis, you said CAD. So please tell us what is your number 1 diagnosis.
Restrictive cardiomyopathy.
Again, say it in full.
So, our provisional diagnosis, first differential diagnosis, restrictive case of restrictive cardiomyopathy, presently NYHA class 4 symptoms.
When you say restrictive cardiomyopathy, you have to say right-sided, left-sided, biventricular, which one dominant?
So, right ventricular, sir.
But then he has so much dyspnea, and even
These symptoms are all on the right side, then on the left side, sorry. And you are saying it is all right-sided restrictive cardiomyopathy. That is
biventricular, sir. Biventricular.
Okay. What else is the diagnosis? Any other differential diagnosis you have?
Sir, CCP, constrictive pericarditis, but there is no knock. We were unable to hear any knock.
Present as well is not also like constrictive pericarditis. Yes. CCP is present as well is different.
So,
this S3 and knock, how will you differentiate?
S3 and first the duration and the speech of the sound, and the S3 usually occur later in diastole, but the pericardial knock is early in the diastole. And the pericardial knock is a high pitch sound, and S3 is low pitch sound, sir. The pericardial knock is heard bass, and the S3 is palpable bass rather than the auscultation.
Yeah.
Okay, I think you have to tell us the investigation because we haven't reached any diagnosis. Restrictive cardiomyopathy doesn't really make, explain the symptoms and the features that you've said, right, especially right-sided, because all the features are left-sided. Patient is class 4 dyspnea, dyspneic at rest, which is a very, very major major symptom that you have to explain, which is very difficult to explain with restrictive cardiomyopathy of the RV type.
Restrictive cardiomyopathy, what type of restrictive cardiomyopathy is in your mind?
Sir, we were thinking of amyloidosis, especially if we go on to investigation, the ECG.
No, not investigation, from the history. No, what are the other possible clinical features or symptoms which will point to a feature into a diagnosis of amyloidosis?
AIDS, sir. Then no family history.
More than 50 years.
Go ahead.
I think we should go ahead. We can. It is already nearly half an hour.
Yeah.
20 minutes to be precise.
Moving on to investigations. Chest X-ray, there was bilateral minimal pleural effusion. There was no cardiomegaly. This is the ECG.
Again, your X-ray is incomplete. No, we need to know about pulmonary venous hypertension, pulmonary arterial hypertension. Just saying no minimal pleural effusion, no cardiomegaly is not enough.
You could have shown
the diagnosis depends on it. You have the X-ray or you don't have?
No, sir, we don't have that.
So when you interpret an X-ray in cardiology, is that all you talk about? Cardiomegaly and pleural effusion? So because your diagnosis is not even certain right now. We are depending on so many things on X-ray and other investigations. So you should talk about PVH at least in somebody who's class 4. You have seen the X-ray or you haven't?
Yes, sir, we have seen.
So please tell us if there was a PVH or not. You should have brought a picture.
So any calcification, any other findings, so many things, no?
Okay. No cardiomegaly and no pH or PVH on X-ray.
There is no pericardial calcification seen in the X-ray, and there is a solution of pulmonary venous hypertension in the X-ray.
So how severe is pulmonary venous hypertension on X-ray? How severe?
What is the grade of pulmonary? How do you grade pulmonary venous hypertension?
Mild, moderate, severe, and how?
I think you go to the ECG because you don't.
Yeah.
To the ECG.
So this is the coming on to the ECG. This is the ECG, sir. We could see prominently low voltage complexes, and the axis. The patient was in sinus rhythm. The ECG is showing sinus rhythm, normal access, normal access.
Normal access.
Outcome normal access.
No, indeterminate access. Sorry. Am I audible?
Yeah, you are audible.
Yes. Yeah, you are audible.
So there was poor progression of R wave in the precordial leads, and
what is the definition of low voltage?
Low voltage less than 5 mm and less than 10 mm, less than 5 mm in limb leads and less than 10 mm in precordial leads.
Okay. Okay.
So
what does this help you in your diagnosis? You also have to say about STT changes because you are thinking of CAD.
That is what there were no STT changes, significant STT changes, and at the same time, since we are getting low voltage complexes and we are thinking of restrictive cardiomyopathy, so basically our diagnosis on the basis of this ECG we can think of amyloidosis as a cause of that restriction.
You have to say about absence of Q waves. Poor progression of R wave can be a indicator of ischemic cardiomyopathy also.
But then
so say that there are no Q waves.
There are no Q waves. Definitely, there are no Q waves on the ECG. But at the same time, there is poor progression of the R wave, but no Q waves are present. So,
any comment on the atrial enlargement or abnormality?
On left LAA, left atrial abnormality, P terminal force was more than 0.04.
V1.
So that is also important finding, no?
So moving on to echocardiography, we should once see the slide, the video, and then we'll talk about the.
Go on showing.
So so our calculation was on the echocardiography, the LV-IDD as well as IDS was 4632 with an EF ejection fraction of 65%. There was no RWMA. There was concentric hypertrophy. IVSD or LVPWD was 15 and 15. We could see the RA and LA to be dilated. The left atrial volume index was 47 ml per meter square, which is severely increased. At the same time, RA area was 27.4 centimeters square. The RV fractional area short contraction was 19%. The TAPSE was reduced 11 mm. 11 mm. The RV S dash was 7 mm. The RV lateral wall thickness was 8 mm. And the RV GLS was minus 14.5%. And if we can see this, there is the plaques view. We could feel the myocardium. There was sparkling pattern on the myocardium, appearance of the myocardium, basically. So now in this one, the peak E velocity, we can see the MV peak E velocity, the deceleration time, as well as the A velocity.
There is E by A ratio 4 and IVR is 67, which is very less in RVR. So we came to a conclusion that gate 3 diastolic dysfunction, and the propagation velocity is 40 centimeter per second, and E by propagation velocity is 1.8. This has there is a LV end diastolic pressure around more than 20 over on echo, and there is no septal bounce in scene on flex long axis view, and the medial E prime is 2.71 and the lateral E prime is 3.38, and there's no suggestion of any analog paradoxes is seen. But both the lateral and medial E prime are reduced, and E by E prime is 23. There is a hepatic vein flow reversal, which is more on the inspiration is seen, and there is no respiratory variation in the mitral and tricuspid flow with respiration is seen, and there is moderate tear and IVs are dilated with 50% respiratory variation, and the RVSP is 48 mm Hg with a mild MR
How did you calculate RVSP?
RVSP is calculated by right atrial pressure.
How much is RA pressure?
RA pressure is around 10, sir.
Why you had a JVP?
JVP of 16 centimeters.
JVP was 11 millimeters or 12 millimeters of mercury. So what is RA pressure?
Then there is 38 plus 15, around 50. And 50 there will be the RA pressure, systolic pressure. And the IVC will be dilated and the 50% respiratory variation and the mild MR, the thickened mitral valve seen, there is no AS or AR is seen. And the global longitudinal strain is minus 12.5% and the global circumferential strain is minus 23.1%. With the relative apical sparing seen in the global longitudinal strain. On hemodynamics, the right atrial pressure.
I think you pause. Please pause. Yeah. Please pause. Please pause. Did you talk about interatrial septum? Atrial septum.
It is intact and thickened.
So please show us the
thickened. You don't know whether it is thickened. Yeah, I didn't. Interatrial septum. No, show the fourth chamber of CN. No, show that. Yeah.
Okay.
See, till now you have told us about diastolic dysfunction of both the ventricles. That is all we know. And there is systolic dysfunction of the right ventricle. Is that correct?
Yes.
All these features that you are showing us are just pointing to that. Or is there any other information you've got? Moderate TR, mild MR, elevated RV systolic pressure, elevated RA pressure, and diastolic dysfunction of the LV with thickening of the wall and systolic dysfunction of the RV. Is there anything else you want to tell us from echo interpretation?
No, this there's no RV systolic dysfunction and the only RV diastolic dysfunction.
RV systolic dysfunction, not there. Your TAP says 11.
TAP says 11, then why are you saying that?
No, I'm sorry. There's no RV systolic dysfunction and only.
Please come to the mic.
There's no LV systolic dysfunction.
Yes.
Only there is RV systolic dysfunction with LV diastolic dysfunction.
Yes, that's all you've been able to tell us till now. The question is, what sort of cardiomyopathy is it fitting into?
So it may be respiratory cardiomyopathy.
Okay. Anything more than more information?
Probability to amyloidosis.
Why?
Because there is a thickening in amyloidosis, but then other respiratory cardiomyopathy, there is more thickening of the ventricular wall is seen with sparkling pattern. So we provisionally think of amyloidosis. Along with that, there is a global longitudinal strain is diminished with relative apical sparing pattern. So it's more fought toward cardiac amyloidosis.
So that is the reason why you should have looked at interatrial septum.
What is the reason for the thickening of the mitral valve? You said mitral valve is thickened.
So there is a valvular infiltration. If there is amyloidosis due to valvular infiltration, there will be thickening of the mitral valve.
Okay.
We are almost, time is almost over, 2 minutes.
Oh, forward. Yeah. Any other investigations then?
Hemodynamics. On hemodynamics, seen right atrial pressure 20 mm Hg with prominent Y descent and blunted X descent with right ventricular end diastolic pressure 15 mm Hg, systolic pressure is 47 and RV end diastolic pressure by RV and systolic pressure 0.31 with LV end diastolic pressure 20 mm Hg and LV end diastolic and RV end difference is 5 mm Hg. So the final diagnosis is restrictive cardiomyopathy in a congestive cardiac failure, NOH class 4, probably due to amyloidosis in sinus edema.
So what would you like to do?
Further, sir, ma'am, we would like to go for any cardiac MRI and biopsy.
You have that?
No, ma'am.
Okay, what are the what will you manage?
If we go for cardiac amyloidosis, since it is a isolated cardiac amyloidosis, I don't know any systemic feature other involved. So we rule out we can see for any paraproteinemia or any kidney involvement is there. Then we go for either chemotherapy or cardiac transplantation. Best is cardiac transplantation is followed by chemotherapy.
Okay, what is the pattern you expect in cardiac MR?
Cardiac MRI, we normally see that diffuse subendocardial late ganglion enhancement is seen.
Do you know the various types of amyloidosis for cardiac amyloidosis?
Yes, mainly there's 4 types of cardiac amyloidosis. Primary amyloidosis, which is mainly involved all the system, including heart, except central nervous system. Second is primary familial amyloidosis, that is due to ATTR mutant variant. Third is senile system amyloidosis due to wild type ATTR, and fourth is atrial amyloidosis due to ANP deposition, and fifth is secondary cardiac amyloidosis where cardiac amyloidosis is very rare.
What is the new therapy which has come in amyloidosis?
During ATTR, we can use tafamidis as a new therapy to prevent formation and excretion of the mutant unfolded ATTR which is deposited.
Okay, what is the type of amyloid which occurs in dialysis patients?
Mainly dialysis B microglobin deposition is there. Mainly the regions in dialysis patient. Beta microglobin.
In the late gadolinium enhancement that you talked about in MRI,
yes.
How do you differentiate amyloidosis from ischemic from other causes? Are there
mainly in amyloidosis, we see the diffuse involvement, which is subendocardial basically, but in ischemic, the regional late ganglion enhancement is seen in the regional territory, either LRD or RCA, and other in sarcoidosis, which is mainly a patchy involvement, which is mainly in the septum, either anteroseptum or interval is mostly involved in the middle basal part.
Can you think of any other diagnosis other than amyloidosis? Or you are very, very sure that it is amyloidosis?
Yeah, what is the reason for chest pain? You said angina all through. So what is the reason for angina in this patient?
In amyloidosis, there may be infiltration of the small vessels, which can present a patient with exactly like chest pain due to angina. Angina like chest pain will be present in amyloidosis due to infiltration of the small vessels by amyloid protein.
You mentioned you will do MRI and cardiac transplant. Do you want to do a coronary angiogram with this patient? Because you have already done the cath. No? What is the coronary angiogram finding? Because patient had angina.
Sir, since during the cath study the patient deteriorates, so we can further go for, since the stabilization we cannot go for coronary angiogram till death, sir. It is important.
No. Did you do the cardiac cath? No. Did you do a coronary angiogram at that time?
At the time, during the cardiac catheterization, the patient deteriorates, sir. So we have to abandon the procedure and for the next till the stabilization.
Okay, I think it is time.
Okay.
Okay. Thank you.